she is independent in her basic activities of daily living. So there is no history of suggestive of REM behavioral disorder, no history of sleep apnea or stridor, no history of visual hallucinations, no history of losing ways or bumping into objects, no history of difficulty in recognizing familiar persons, no history of rigid behavior or impulsivity, no history of lack of empathy or sympathy, no history of decreased self-hygiene, no history of change in dietary habits, no history of unprovoked falls. There is no history of loss of consciousness, seizures, decreased communication or trouble understanding or reading. There is no history of loss or perversion of smell or taste. There is no history suggestive of cranial nerve dysfunction. No history of gait disturbances. No history of twitching, tremors, fasciculation, or any involuntary jerky movements of the limbs. No history of bowel and bladder dysfunction. No history suggestive of sexual dysfunction. No history of weakness or sensory loss in the limbs. And no history of autonomic dysfunction. There is also no history of any systemic symptoms, fever, joint pain, rash, or significant weight loss in the past. Past history is nothing significant. Personal history, she's married, 2 sons, housewife by occupation. She's educated up to 12th standard. Bowel, bladder, and appetite is normal. Diet is vegetarian. There is no addictions. Family history is nothing significant, sir. So summary, a 52-year-old female presented with insidious onset, gradually progressive memory impairment in form of predominant episodic memory since 1.5 years, with dysexecutive function in form of working memory impairment, perseveration, slowing speed since 1 year, and behavioral changes in form of decreased interest in hobbies, easy distractibility, disinhibition, and agitation since last 8 months. So, should I go ahead, sir?
Just go to the first slide, the second one, where you started explaining the problems.
Yes.
The next one.
Yes,
yeah,
sir.
Fine. What I have noticed is that when the exam is going on, the examiners, especially in a dementia case, they are devoting most of the time to the history. Therefore, yes. And the history, what they want, they should be narrated in the form of a story. For example, the third point in which you told that her husband was supposed to come late. In fact, that could be a starting part. One fine day, that's the story. They want events.
Okay.
And after the events, then you can go back and say some generalized statements. What was the most important event which told the family members, no, there is really a problem? That is the primary event, and that should be spoken in detail. That's what the examiners want. Normally, when we start saying that the patient had a memory loss. Yes. That is our interpretation. History, there should be no space for our interpretation. It should be as the attendant told me.
Yes.
That suddenly the one evening when my father told that he will be coming late, but mother couldn't remember and she kept on asking. That is the primary event, then that should be spoken. And forget objects, this all, it means that's the family members may say that, but that should be a later part. A primary event should be discussed in detail.
Yes, sir.
Yeah. How do you analyze this statement?
This statement, sir?
Yeah, the third statement. What is the suggestion? What is the problem here?
So basically, she forgot the detail, the episodic memory, because she forgot the event which happened few hour or few minutes ago, and she keeps on repeatedly asking the same thing. Even when her son answered her the same thing, she kept on repeatedly asking the same thing. So it implies that there is some problem in episodic memory, and also autobiographical memory, because her
what maybe she has not registered even. Therefore, therefore that's the point. This is a typical suggestion. And this is the story of Alzheimer's patient. This particular event, and they can't register the events. And this type of starting always should make us think that there is a memory which is being involved. Let's go forward. Next slide.
Sir has to change that.
RK, are you there? Okay, fine. Fine. I saw the story. Now, I would like to ask. She had difficulty in cooking. What all cognitive domains are involved in cooking? Because that was the next problem, isn't it? She
Yes.
took a lot of time in cooking, and after that, that also she was not sure.
Yes, sir.
Therefore, is it only memory that matters, or is there something else also
Yes,
that
sir. There
you
are many.
think about and you should bring that out in the history?
Yes, sir. So for cooking, mainly the memory of cooking should be there. First of all, how to cook. She should remember the things how she used to cook before. So that should be there. Again, while cooking, steps should be taken in proper way. So attention is also there to uh, maintain the track on the cooking.
Yeah.
We have to do.
This. Sorry to interrupt. This is called as sequencing,
Yes,
right?
yes, sir.
Sequence.
Yes.
Sequence. Therefore, which part of the brain is involved in sequencing?
So for attention, it is a
No,
frontal lobe basically.
sequencing. Frontal lobe is a big part of the brain. Which part will you say that
Parietal lobe.
dhaka tak, dhaka tak, we do early morning, we don't think, we do many things at the same time. Which part of the brain is involved for that?
So that will be then procedural memory, implicit memory, which will be in supplementary motor area, basal ganglia, cerebellum.
1 second, 1 second. Uh, Cycling is a procedural memory,
Yes, sir.
right?
Yes, sir.
I'm not talking that. Cooking is a cognitive art,
Okay.
right?
Yes.
It's not cycling.
Then the
Cycling,
parietal.
yeah. No,
Because
madam, it
in
is frontal. What are the parts of the frontal lobe? Tell me, you yourself will answer it.
yes, sir. So dorsolateral prefrontal
Correct,
or
correct.
biofrontal and medial frontal.
DLPHC is the part, most important part of the brain, which is
Yes.
in which we do this cooking and all. Therefore, apart from the memory, sequence is one other important thing which is needed in the cooking. Next, what else domain is needed?
So executive function, planning.
Yeah, that all is DLPFC. That all is
Yes.
execution, sequencing, planning, all is part of DLPFC.
Yes.
Therefore, only we cannot just generalize it to the medial temporal lobe. A
Yes.
part of the dorsolateral PFC is also very important. Therefore,
Yes.
when you take the next history, where you make up that you should go in that direction. Okay,
Yes.
RK, are you there?
Yes, sir.
Yeah, fine. Just go back. Yeah, fine. Next slide, please. Right. Forgetting, switching off, and all, switching off, turning off gas. What all can be the problem here? We all know memory is the only thing, but you should also keep your mind open and think what all can be there.
Yes. Attention also should be there in
Yeah.
turning off,
Yes.
and
Attention.
episodic memories should be there because ones have to remember that we are doing something and we have to switch it off when it is
Yeah.
done.
First, memory is important.
Yeah.
Attention is important. Third, I have difficulty in changing channels. I have
Set
difficulty in using
shifting,
buttons. What is that?
executive set
No,
shift.
no, 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 no. I can't use the remote control. I can't use my cell phone. I can't make a call. I can't use the numbers, buttons proper. What is that suggestive of?
That is also again executive dysfunctions.
Along with that,
Planning, programming, judgment.
judgment. There is no role of judgment here, isn't it? Using a remote control is a learned activity, isn't it?
Yes, sir.
Therefore, a
In
practice comes
procedural
into
memory.
this also.
Yeah.
Therefore, the thought of higher learned activity is going off. Therefore, you think of a temporal lobe, you think of a frontal lobe, you think of also practice disturbance. It can be of various forms. You
Yes.
have to keep in mind all of this. And later, when you formulate the history, what you want to say, you have to say. Okay, fine. Now coming to the financial issues. What are the parts of the brain involved in the financial issue? What are the domains may be involved?
Domains, first of all, episodic memory,
Yeah,
then this executive function, working
yeah,
memory attention, working memory impairment,
yeah.
then cognitive slowing of speed, also
Okay.
behavioral changes in way of in form of apathy, easy distractibility, disinhibition.
No, no, no. The common things, common things. When you have money, what do you do?
Sorry, sir.
When you have money in your hand, what do you do? You count, isn't it?
Yes, sir.
Yeah.
Calculation.
Before telling judgment, before telling disinhibition, common things are counting, identifying whether this is a 500 rupee note, 100 rupee note. Then
Yes,
you
sir.
have to do the calculation. Then you have to mind what I have to keep, what you have to give. Episodic memory, DLPFC, executive, calculation, all come into the history.
Yes,
Okay,
yes.
go forward. RK, next slide, please. Yeah, this was a. What do you think about the sound? What do you think about? I couldn't make up my mind. Distractible with any sound. What do you think about it?
Sir, sometimes if some noisy sound is coming, so she used to lose the track from concept conversation, and she used to get distracted with it. So that's what.
What do you think? Is there any relation in our story?
Basically, attention, sir. Attention. She's not able to attend to some event or some whatever topic is going on. She is not attentive to that. To that, concentration is impaired.
Okay, fine. Go ahead. RK, next slide, please. Yeah, this is a very important slide. She became very angry with herself with repeated mistakes.
Yes, sir.
What does this show about the patient's mind?
That means her insight is preserved, and
Very
she
good, very
knows
good.
she is making mistakes. So that insight will be preserved in Alzheimer's patient basically, and will be impaired in frontal temporal
Yeah,
dementia.
grossly, what we are taught early in the story that in patients with memory disturbances, dementia, they won't have insight. But
Yes,
we see day to day is that especially patients who have episodic memory, they have a good insight. They will
yes,
say that, sir, please help me. I'm not able to do my activities. Therefore, I agree with you. A frontal behavior variant, they won't have the insight, whereas a patient having a temporal, they will have early insight. Later in the disease, the insight may go. That's a different issue. But early in the disease, insight is present, and the it's good that you could make out that about that presence of insight. Reading disturbance next. Where do you place the reading disturbance in the cognitive domain?
so basically here she was disinterested in reading. That means loss of interest in her hobbies, which were she used to do previously. So that here it is basically apathy.
Yeah,
And
1 minute, 1 minute. Till now, we are all thinking predominantly of a temporal lobe, isn't it?
yes, sir.
When we have a problem, why
Mm.
should we put it? Why should we go to the frontal? Can we adjust it in the temporal by any way?
So that there can be some uh, agnosia or something like that. That
Difficulty in reading, difficulty in identifying the letters.
yeah, fusiform
Therefore,
glasses or
yes, I would like to keep it more near the temporal and the parietal rather than take her to the frontal, because all the symptoms what we have, we don't have much frontal coming into the picture.
yes, sir.
Therefore, this also reading disturbances, whether I would try to go, whether she go deep, whether she had difficulty identifying the letters or whether she had forgotten how to read, that I would like to know before commenting whether this is the temporal. I would like to still keep some reading disturbance in a temporal, rather go as apathy going to a frontal. If
Okay.
there had been a history suggest of apathy, I would keep it apathy. But here there is no history. In fact, she was angry on herself that she is making so many mistakes.
Yes, sir.
Therefore, I won't bring frontal, but I will try to keep it as a reading disturbances as a part of temporal involvement.
Yes, sir.
Okay,
Yes, sir.
fine. Next, the hurtful manner. How do you interpret that?
That is again, sir, matlab, there is a disinhibition, social disinhibition. Kind of
Social disinhibition is, I will tell you clearly. For example, unconcerned about behavior, micturating in the public, profanities, obscenities, these are disinhibition.
Yes, sir.
Hurtful behavior is not disinhibition. This
Okay.
can be her anguish, unable to perform simple things. We'll keep it simple rather than take it to a frontal lobe.
Okay, sir.
Yeah. Go forward. Go forward. Next one. Yeah. Fine. Next. Yeah. Yeah. Next slide.
Sorry.
Yeah. That's okay. Therefore, can you again summarize? In summary also, we would like first you to summarize as the history, then you can tell where it is, which domain is involved, which part of the brain is involved. Can
Okay.
you summarize the history as told by the attendant in 5 lines?
Yes, sir. So
Yeah.
52-year-old lady, a housewife, came with history of insidious onset, gradually progressing, forgetfulness in terms of forgetting the event, forgetting some episodic events, also repetitive questioning, difficulty in her day-to-day activities like cooking, and increased slowing of speed in doing her day-to-day activities like cooking, decrease in her interest in her hobbies like reading, uh, becoming angry with herself about her repeated mistakes. This all goes to basically episodic memory.
Yeah,
Also,
fine. Without involvement of,
without involvement of there is also dysexecutive function and behavioral changes without involvement of the, any extrapyramidal symptoms, no involvement of gallbladder involvement or any other focal neurological signs. So should I tell negative history?
yeah, you can. Important negative histories can be told.
Yes, sir. So there is no history of REM behavioral disorders, no visual hallucinations.
Yeah.
This for I asked for DLB. No history of losing ways or bumping into the object for visuospatial function. No
Very
history.
important. Very important, because when we talk about 1 year history of episodic, the history of the losing way should come. That should be brought earlier.
Yes, sir.
Mm.
Then no history of difficulty in recognizing familiar persons like
Okay.
prosopagnosia. No history of rigid
Very good.
behavior. Any the frontal features like rigid behavior, impulsivity, lack of empathy, sympathy. Again, there is no history of decreased self-hygiene, any some part of executive dysfunction. No history of change in dietary habits, again for frontal temporal dementia. No history of
Fine.
unprovoked
Fine.
fall.
Fine. Then summarize these symptoms to the parts of the brain involved.
Yes, sir. So the brain parts of the brain involved, first is medial temporal lobe,
As suggested by.
episodic memory impairment and repetitive questioning.
Very good.
Then
Next.
then there can be subcortical connections in view of
No. Don't go to subcortical. This is all cortical only.
right, sir.
Next part of the brain involved.
Frontal, dorsolateral prefrontal cortex, executive
How come?
dysfunction.
How come? How
So
come? What are the
executive,
symptoms which suggested?
it suggested with the this thing loss of concentration, easy distractibility, working memory impairment, and executive cooking,
Correct.
his
Correct.
ability to cook and day-to-day
Correct.
activities.
Correct. And also
And
a little
media,
calculation involvement was there. Is
yes.
there anything in the history which you would like to further discuss on after examination?
I have
The
to.
reading part. The reading part. We have to
Yes.
establish what is the problem with reading.
Yes, sir.
Fine. Okay. Now,
Yes.
what is the, we finished the anatomical, coming
Yes.
to the pathological, followed by etiological diagnosis.
Yes, sir. So pathological we localize to medial temporal.
That
Matlab,
is anatomical. That is anatomical.
yes, sir. It is a basically it is a 1.5-year history of gradually progressive illness, and without any prior history of any systemic symptoms or fever, joint pain, rash, or any other infection. So I would like to keep it as a pathology as degenerative. Matlab, sir, it is a rapidly progressive degenerative course.
Fine,
Or
fine. First is degenerative. Agreed.
sir,
Uh, age is 52, young, isn't it? What
yes,
else would you like to keep into the picture?
I also like to put any metabolic deficiency because she is vegetarian by diet,
Correct.
and so I have to we have to rule out any vasculitis,
Okay, correct.
autoimmune, and it is also
Vasculitis. No, I'm talking about the pathology. Pathology is one is degeneration. The second
infection.
is infection,
Yes,
inflammation,
inflammation.
demyelination. As in, because young age, I don't want to miss any treatable cause.
Yes, sir.
Yeah, that's good. Etiological diagnosis.
So etiological in neurodegeneration, it could be early AD or early Alzheimer's disease with frontal variant, or other etiology will be infection. As we said, we have to rule out HIV. Then also chronic meningitis. In metabolic, we have to see for any metabolic factors like B12 deficiency, hypothyroidism. Other like vasculitis, autoimmune, and paraneoplastic, we have to search for because it is a early age and with little rapid progression.
Yeah. Okay. When do you call early onset Alzheimer's?
So less than 65 years.
Okay. Routine is more than
More
60.
than 65.
Therefore, yeah. Routine is more than
Yes,
60.
sir.
Therefore,
Yes.
prior that, you should always think of a early onset dementia. Fine. Fine. Vasculitis, I'm not, yeah. As she is young, I would like to keep the diagnosis big enough, right?
Yes.
Wide range.
Yes.
Fine. Any other suggestions? Ramakrishna, Vishal sir, please suggest.
No, I don't have suggestion. I am learning, sir.
Dr.
Sir,
Mohan and Dr. Veda also can ask some question.
Sir, as usual, is there any reversible cause of dementia in this patient?
yeah, totally agree. Young patient, I would like to keep everything before putting a degenerative. I'll try to keep full. I'll keep my mind open and try to bring all the possible treatable causes. Okay, fine. We'll
So,
go to
just one small question. I'm Dr. Mohan Manager. Involving the money involvement actually. I think visual agnosia also plays an important role. So visual gnosis that may also play a role. So that is one thing I want to add on. And other thing I want to ask the presenter, how does HIV associated dementia actually
Sorry, sir.
HIV associated dementia? Or what is the features, main features? Like,
So it
is
is
it
a
similar to the
subcortical
presentation,
dementia.
sir?
Behavioral features
Yeah,
will be
so it's
present.
predominantly behavioral,
Yes, sir.
and yeah, okay, and it's subcortical.
Subcortical.
Yeah, okay,
why did you
okay.
bring
And,
HIV here? Because of the sister's history, is it?
Yes, sir.
Oh, fine. Okay.
Mhm.
Yeah.
is there any point against an autoimmune or paraneoplastic here? Like,
Again,
what all would you think against an autoimmune or paraneoplastic?
sir, basically there will be some movement disorders, psychiatric, lot of psychiatric features.
1 minute, madam. First positive, then negative.
Yes, sir.
So,
Positive
what are the
young
features as
age
they are told
and
for?
rapidly progressive. So positive will be young age and rapidly progressive.
Do you think the onset and progression is for or against the autoimmune and paraneoplastic?
For
You
sir.
said you said it has been 1.5 year duration, right? Usually, what is the onset and duration of? Do you think a patient with paraneoplastic or autoimmune like will have a preserved basic ADL after 1.5 year of history?
No, sir. That will be little odd, sir.
So usually it's a subacute 2 to 3 months in months history, both autoimmune and paraneoplastic. So that
Yes.
is a very odd point here.
Yes, sir.
So whenever you give the possibilities, it's always better you just say argue for and against.
Yes, sir.
So that will give a better picture for the examiner. Also, they will be more convinced that you know why you are thinking and why you are not thinking. So
Yes, sir.
and someone just raised a question from the I think Dr. Shobna asked about how to differentiate between an ideational apraxia and executive dysfunction. I'm not very sure. I think it is mainly by examination we do that. So whenever a patient is not able to perform a sequence of events, like for say cooking difficulty, the patient is not able to do a series of events. So you always, as Sir told, it's better to tell what are the possibilities, what are the structures could be possibly involved. Like it could be a immediate working memory involvement, executive dysfunction, the recent memory, medial temporal, or it could even be an ideational apraxia, the sequence of events. So it's always better to give a DD like this and then go for I would confirm it by examination. That would be a better thing. But I
Yes.
don't know, Praveen sir, do you like someone raised this question? I don't know how to differentiate from history. Ideational apraxia versus the executive dysfunction. Hello, Praveen sir.
Praveen sir left, I think. Where maybe busy.
Okay.
Anybody else? Anybody having any other questions?
Yeah, for the discussion sake, can you please highlight about the which is the most common dementia? When do you get neuropathic symptoms? When do you get neurological problems? Just 1 minute discussion. Am I audible?
Yes,
No,
sir.
voice is not clear.
Yeah, please discuss about the B12 deficiency. When do you get the neurological problems? When do you get dementia? When do you get hematological problems? How much time? What is the duration?
So the B12 deficiency, sir, we can get subacute combined degeneration like with posterior column involvement and lateral column corticospinal tract involvement. We also can get peripheral neuropathy and cognitive decline and optic neuropathy. So for B12 deficiency dementia, we have not seen it is so.
There also it is predominantly attention involvement actually.
Yes, sir.
CJD, what do you think? The points for and against again here.
So CJD is also for is young onset, but against is it is too rapid, too slow for CJD, because for CJD it should be like within 6 months to 1 year the course, and there is no any myoclonic jerky movements or any other symptoms. Sir. So basically course is too rapid, too slow for CJD. By this time CJD patient should have either death
So if
or
it is an Alzheimer's, I think here it is like you're thinking more of Alzheimer's. So if it's Alzheimer's, what grade? Like is it mild, moderate, or severe? Or
moderate, because mild they will be episodic memory impairment, anomia, and they will be instrumental ADL will be impaired. In moderate, actually it is mild to moderate. Moderate will be aphasia, then there will be the basic ADL also will be impaired, and severe will be they are almost dependent for all activities, and they are
predominant behavioral abnormalities will set in.
agitation. Yeah, yes, sir, sleep disturbance, agitation.
Yeah, one question from one participant: how to ask utilization behavior in history?
Last time also we got the same question, I think. Dr. Mohan has to clear this.
Yeah. So actually, utilization behavior is when the patient starts using objects which are in front of his or him or her. Like you just place some object in front of the patient will start picking up and start meddling with it. So it's just a observation, something we see by observation. So that is
Yeah,
utilization behavior.
yeah. Can I add a point here?
Yes,
I'm
sure, sir, sure,
audible,
sir.
I think so. At that time, somehow
Yes,
I
sir.
had muted, therefore I was not able to speak.
Okay,
Uh,
sir. Okay.
yeah, I totally agree. Utilization is a part of the what we see, but uh, these are the set of symptoms when we think is that when the frontal is very much frontal behavior is unmasked. For example, when we get a history that the person hoards things, a person has a specific appetite towards something, person is behaviors are to a particular thing is there, then you should think that, oh, then you should look and try to place something in front of the patient and see what he does. Then that comes. Usually we don't ask about utilization behavior in the history, but it's a part of an examination.
Yes, sir.
One more small addition. Actually, you told the patient is asking questions repeatedly, right? Like
Yes, sir.
what else could be the cause? I'm not in this case. It's definitely a involvement of recent memory. But what else could be there if a patient is asking repeatedly the same things again and again, or doing the same things again? Like, is that any specific behavior?
Perseveration.
And where does it go? Localization.
Frontal, sir. मतलब dorsolateral, prefrontal. Stereotypical behavior.
So is there any difference between echolalia and this perseverance?
So echolalia means patients will repeat whatever examiner is saying.
Okay.
So that will be different. So perseveration means he will do the same thing again and again.
So you told one more thing: the patient is able to recognize the faces of the peoples, right? Like
people, yes, sir.
okay, and also some remote events and all. She's able to remember something like that. You told, right?
Yes, sir.
Okay. Because is there what is the Ribet's law?
Report's law is, sir, whenever there is injury, so
Okay.
the recent memory will be lost and remote memory will be intact. So remote memories are resistant for injury. So basically, it applies in the head injury patients or any damage to the temporal lobe.
Could this be AD with frontal variant? You've given
Sorry,
the
sir?
second DD. You've given this a second DD, AD with frontal variant.
Yeah, sir. Because this Alzheimer's disease variant is one of his frontal variant, because in this patient, a lot of behavioral.
Insight is very much preserved, right? So
Yes, sir.
Yeah.
and also the frontal features are not much predominating. So I don't think.
I agree. Many of them can be explained by the temporal only.
Yes.
Therefore, the thought about the post-herpetic encephalitis, that also shouldn't come.
Yes.
That may be the 6th or 7th differential, not the 3rd.
Okay, sir.
B12 will come up, hypothyroidism may come up, autoimmune versus paraneoplasm comes down. Infection, because we don't have a history of infection.
Yes, sir.
Therefore, any flu virus infection, you want to say something that you can say, but not at all. Definitely not a post-herpetic encephalitis.
Right.
Can we go ahead?
Yeah. Yes, sir.
So examination, general examination. The pulse is 92 per minute regular. BP is 140 by 19 supine position and 130 by 18 standing position. No pallor, cyanosis, clubbing, lymphadenopathy. No other urocutaneous markers. And skull and spine is normal. CNS examination. She is conscious, cooperative, but anxious look. Digit span is forward 6, backward.
One second. What would you have on the examination in dementia? What they first say?
What, sir?
In the general examination or in the first part of the field, what would you first say? examination, general examination.
I did not get your question, sir.
Yeah, in general examination pertaining to cognition, what is the first point?
Behavior, matlab she is cooperative. Behavior, how is her mood?
Behavior, until you ask, you don't know. Appearance wise, what is the first thing you will say? Because you thought of frontal. How are the frontal people dressed or behavior, or how do they look?
Yeah, they will be matlab untidy,
Yes.
non-hygiene.
Therefore, the first point in cognition, whether you can place it here or in the CNS first point, how
Yes.
is she well dressed, or
Okay.
how is the hair tidy or not, and how is her general look? That
Yes.
should be a. You can keep it anywhere, but make it a point to definitely write it.
Okay.
Because if some person comes with untidy and unruly hair, you can surely, oh, this is a frontal. Or if somebody is wearing a flashy dresses, that also frontal. Or somebody maybe just unconcerned. Therefore, what is the general appearance? There should be a point about that.
Yes, sir.
Okay.
So
In examination, we go by slide slowly.
I think educational status of the patient is also an important point in the examination. So
yeah, you can again reinforce it here.
Okay, sir.
So if you want to ask any questions in the examination, we will discuss here only, slide by slide.
Yes, sir. So digit span is forward 6, backward is 2. So sir, here matlab backward span, digit span mainly denotes the working memory, attention. Days in weeks is forward 7/7 and backward is 3/7. So next slide is MMSE. It is
what is the difference? Like you told between the forward and backward digit span?
Yes, sir. Forward is immediate memory 6,
Okay.
and it is normally 7 plus minus 2. Backward is working memory, requires attention. So it is normally 5 plus minus 2.
Attention and sustained attention.
Sustained attention. Yes, sir.
Yeah. So forward is usually attention, and
Yes.
backward is
Sustained
sustained attention. Yeah.
Vigilance A, you are not mentioned.
Yes, sir. MMSC 18/13, sir. She lost basically some points in orientation to time and place. The recall was not there. Even with cues, it was not there. And there is a copying diagram is impaired. And calculation that is also impaired. Frontal assessment batteries are 8.
What is your
Questions are MMSC?
Yes, sorry, sir.
Right. कोई questions है तो यही पूछने को मानो.
Yeah. What
Sorry.
is the interpretation from MMSC examination?
So basically, she is majority of the point lost in calculation. Attention is not there. Recall, matlab she is not registering, and even with cues there is no recall. So when the recall is when the patients recall with cues, it can be attributed to frontal FTD, and when there is no recall even with cues, then that will be a registration problem that will go again to the Alzheimer's disease.
with cues and without cues? What is
Yes.
the difference?
So with
If the
cues,
patient recalls with cues, what is the inference?
with cues, if the patients recall, then it is mainly a frontotemporal dementia.
No.
And
No.
Cortical versus subcortical.
So
It
subcortical,
generally implies that it is subcortical. It's not frontotemporal. It generally implies that if the recall improves with cues, it means that the dementia is subcortical.
yes, sir.
Yeah, correct.
Yes.
And here the registration is good, right? That implies that the frontal lobe is intact,
Yes.
right?
Yes, sir.
Okay, so that is important.
And again, copying diagram, she is lost. So there is also constructional apraxia.
Okay.
Calculation, what is the localization?
So it denotes attention, again the dorsolateral prefrontal.
No, specific question. I had
Calculation.
calculation, not at least the attention.
Sir, inferior parietal lobe.
Yeah.
Okay, dominant, non-dominant.
Dominant, sir.
Yeah. Recall.
Recall, again, sir, it goes to frontal, sir. Frontal for retrieval.
No. Recall is what domain is involved?
Sorry, sir.
What is the domain involved in recall?
Recall is holding. It is and again
Memory. Right. So registration
memory.
is attention or working
Yeah,
memory,
registration.
and recall is
And episodic mainly, sir. Mainly medial temporal
recent memory. Yeah, medial temporal.
memory. Yeah.
That's a temporal.
Medial temporal.
Dominant temper.
Yes.
So sir is specifically telling it is dominant. So what happens to non-dominant temporal? Where is that involved?
Sorry,
Like
sir.
left temporal is involved in verbal recall, sir is telling, and right temporal goes.
Visual recall, sir.
Yeah. Then repeat it. Okay. Copying diagram. Where is it localized?
It is again constructional apraxia. So right parietal,
Yeah.
non-dominant parietal.
So here reading is good. So the
Yes, sir.
hobby of not able to read.
Yes, sir.
That is something you are checking here.
Yes, sir.
Okay. So from MMSE, what is the localization means? Which domain are involved?
So
Summary.
memory, episodic memory,
Yeah.
attention, and praxis, constructional apraxia basically.
Yeah. Okay. Next.
So frontal assessment battery, she scored 8 out of 18. So mainly points lost were lexical fluency, motor luria, conflicting instructions, and go no go.
Would you test lexical fluency?
So lexical fluency, I have to ask the patient to tell how many words she can generate from one letter, like FAS, or in Hindi we can say MTK. And in 1 minute she has to generate, and she does not have to include. There should not be any nouns or names of the cities or people.
Are we now till now from the history, and I didn't even think that the fab will be so low.
Yes, sir.
Yeah, this is totally out of the blue. Okay, lexical fluency. What about the category fluency? Did you test that also?
Yes, sir. I have tested in the memory. In category fluency, we have to tell the patient how many names of fruits, vegetables, or animals she can generate in 1 minute.
How was it?
It is also impaired, sir. Category fluency was 5 animals, she told.
Okay. Yeah. Motor luria also gone.
Yes, sir. So next slide, sir. Insight is intact, judgment is intact, graphical luria. So there is she has drawn inside almost on the same drawing. So that denotes the closing in phenomenon. And
what do you mean by that? Where does it take us?
So it is in Alzheimer's disease. So patients tries to just try to draw closely inside the whatever drawing is there. Basically, it is in Alzheimer's disease. Trail A is also impaired. Trail B is not complete. Abstract is intact. Primitive reflexes. So palmomentor only present on left side, but I'm not sure. Pout absent. Glaberar tap is absent. All Stroop is mildly impaired. Anti-saccades normal. Applause sign is absent. Head turning sign is present. Memory
Go ahead. Go ahead. Yeah.
Immediate memory, working memory is impaired. Episodic, 5-word recall affected, and with it improved to with cues to 2. Verbal story, she forgets important details. Remote memory, she can tell.
The
Yes.
problem here is like when the attention is gone, like very difficult to assess your episodic memory, because when frontal lobe are function,
Yes.
so it will affect all the.
Hmm.
Can you go to the other domains? Then we can reflect how bad is the memory. Other domains, how are other domains?
Yes, sir. Other domains like language is okay. Parietal lobe, so cortical sensations are normal. Right parietal construction is impaired. Clock drawing is impaired. So she has drawn outside the clock all the numbers, and also that there is some. Matlab she has drawn 11 after 12. Then 2 she has repeated twice. So there is also some perseveration, and there is no concept also. She has not drawn any hands of the clock. So dressing is intact. There was no neglect.
Yeah. Did you tell her the hands are missing and you have to draw the hands?
Uh, yes, sir. But she was distractible, so she could not do that. I told her, but she was not ready to do it again.
You see that how well she drew the pot, isn't it?
Hmm.
Right?
Yes, sir.
The pot is almost we give full marks, right?
Hmm. Hmm.
And the box she couldn't copy. What does this say? What does this whole of it says? Can you say about the state of the patient's mind? I'm going somewhat forward, but keep everything aside. Look at the way she has copied flower and the pot. What does it say?
So in 2 dimensional she is okay, but matlab, other dimension she is not able to. Uh, she is not able to draw the 3-dimensional or 2 dimensional. She in 1 dimension she has drawn 2 dimensions. So
Yeah,
visual spectral impairment is there.
fine. One thing is that, for example, she is a Indian lady who are involved.
Hmm.
They, what do? They can have a artistic expression is quite good, but
Hmm.
they would have never drawn a clock in their life. For example, stitching and all, they do it commonly, isn't it?
Okay.
Therefore, she could draw the flower pot very well.
Yes.
Drawing such a flower pot says a mind is good.
Right.
Therefore, I will spend more time in the clock and I'll give her cues. Can you put the arrows and show? This
Okay.
one image of a ability to draw a flower pot in such a good manner
Hmm.
says many things about the brain.
Okay, sir.
How many of us draw a cross? How many of us just draw a copy? But if we what we call as muggu in Telugu, that is the floral design which we put in front of our
Rangoli.
house.
Rangoli.
Rangoli, correct.
Rangoli.
If I would have then I would have given her draw a Rangoli, and I'm 100% sure she would have drawn a wonderful Rangoli.
Okay, sir.
You get my point?
Yes, sir. I got it.
Therefore, when we talk about memory assessment or cognition, we have to go to the patient's level and ask,
Yes, sir.
right?
Yes, sir.
In India, we don't remember words, we don't remember letters. It's more figurative. For example, rather than asking for example, letters, you ask, tell me names of gods and goddesses. You will be astonished. They will talk about 30 gods.
Okay, sir.
Right, that's what I say. I think her cognition is much better than what the scores we saw. Go
Okay.
ahead.
Okay, sir.
We have 10 minutes only.
Okay, sorry. We'll go ahead.
So, sir, again parietal. Sir, um, the praxia examination, pantomime was normal, actual object use was normal. All others are normal. Only, sir, um, right left orientation was impaired, finger gnosis were impaired, and calculation was impaired. Next,
Yeah,
sir.
then what we see here is the higher levels are gone, routine or normal.
Yes,
Go
sir.
ahead. Go ahead. Go ahead.
Then occipital lobe is normal, sir.
Yeah.
Cranial nerve examination, all is normal,
One
sir.
second. Just I will just my point, my 2 cents. With
Yes.
all other lobes being normal, I will again recheck the frontal lobe.
Okay, sir.
Yeah, that's it.
How is the remote memory?
Sorry, sir.
Remote memory is normal.
Sir, she told her birthplace. She told the remembers job, but she forgot the year of birth and year of marriage. And semantic memory also was impaired.
Semantic was intact.
Impaired, sir. Impaired.
Impaired.
Yes, sir. Categorical fluency also she told 5 animals.
Okay, fine. Go ahead.
Yes, sir. Cranial nerve examination is normal.
Any
sir.
any other problem? Tell us. That's it.
No, sir. No, sir. No other examination
Okay.
normality.
Fine. What did we get from our after examination? What we got?
Yes, sir. So basically domains involved here are episodic memory. in that both visual and verbal, and also semantic memory is impaired. And in frontal also we got attention impaired attention and disexecutive function. And also
I would like to
visuospatial
recheck the
impairment.
frontal. Okay.
And visuospatial impairment in view of constructional apraxia, finger agnosia, right left confusion. And on from history, behavioral impairment we can see. So.
Fine. Okay. What's your
Their point
diagnosis?
is with so much of frontal involvement. Do you think the basic ADL will be normal? Like, I think what I agree with what sir says. We have to recheck the frontal actually, because with so much of frontal involvement, I don't think she'll be able to do a basic ADL normally.
Yes, yes. So that
I
can
would-
be the attention problem, sir.
I would add one point, please.
Yes.
Just all of us, we should remember that by after taking the history examination, we know what is what, right?
Yes, sir.
Therefore, this is Alzheimer's and the FAB score is wrong. Recheck the FAB score, redo it, whether the patient was inattentive for those 5 minutes, whether
Yes.
something irritated her,
Hmm.
recheck it, and there should be no discordance between the history and the findings.
Yes, sir.
Yeah, that's very important.
Yes, sir.
Otherwise, it doesn't look good. That's it.
Yes, sir. So can we say this is because of inattentive?
Other domains are so good.
Yeah.
Other domains should have gone on testing. Other domains are fine. I somehow I'm not digesting the so much of frontal is gone.
Yes, sir.
Okay. Okay. If we could have good discussion, can we show the images fast?
Images of, yes, sir. I have 2-3 images.
You have it?
Yes, sir.
Describe them fast. Describe them.
Yes, sir.
Fine. This is enough.
Yes, sir. So this is a T1 weighted axial MRI image.
No. This is not T1.
Sorry, sir. Flare image, and this is showing, sir, some frontal atrophy. Also, medial temporal horn is atrophied.
I will not agree. I will not agree. It's normal.
So here in the second image, there is little.
No.
So normal means frontal normal, temporal normal, or both are normal?
So temporal or
What are you seeing? Where is that? In the temporal lobe, what do you mean? Which part is gone?
so anterior temporal pole and some medial temporal part.
There is no medial temporal in this image, in this sequence.
Yeah, but there is widening of the Sylvian fissure.
I would no, I am not much satisfied with the. Okay, you can say that they are deep, but if you just pass off the films to me, I will not you are definitely pointing out the lateral. You want to say about the knife edge atrophy. I'm not convinced. I would look at the more sequences. Are you seeing the sulci? The gyri are almost good. Yeah, there is a deepening. One sulci is deepened, but all others are okay.
Yes, sir.
Okay,
So
fine.
even if you think the Sylvian fissure is deep, like which part of the temporal would be gone in that?
Yes, that is the point.
Lateral.
So it's the
We are not
lateral part.
medial.
Yeah, lateral. We are not thinking about lateral temporal at all in this case.
Only thing semantic memory was impaired in the examination.
नहीं मैडम वो छोड़ दीजिए, इमेज के पास आ जाइए.
Okay.
ये इमेज आया, आपका हिस्ट्री आया, आप क्या करोगे? आर यू हैप्पी विद द MRI suggesting so much of memory impairment in a 52-year-old lady, or will you go ahead? That's my question. If okay, I will suggest. If you want to add something, add. I will. Otherwise, I will suggest.
Sir, you say, sir.
Yeah, I am not happy. I looking at this scan and looking at the amount of problem the patient has, there is a discordance. First point, right? Second, I will go for functional imaging. I'll go for, if the functional imaging also does not show much involvement of the medial temporal or the parietal, I will go for further CSF. I'll try to look for any treatable causes. Was the EEG done for the patient?
Sorry, sir.
EEG.
No, sir, not yet, sir.
Yeah, I think so. This MRI.
We need to see the other cuts also. Yes.
Pardon?
The cuts also. I think we need to see the medial temporal cuts are not well seen, sir. Actually here, so
Agree.
I don't know.
Totally agree. Totally agree. If there is the same amount of involvement even of the medial temporal, I am not sure whether to make a diagnosis of early AD here.
I think in this coronal cut some.
Yeah, I agree.
Mild,
I agree. The sulci are deep and the gyri are thin. But I look at further images before thinking of Alzheimer's here. Okay, fine. Just one point. When you have such a atrophy, what is the grading of this atrophy? And how is the atrophy graded?
Skeleton.
Sorry, sir.
How is the atrophy graded? Brain atrophy graded. What are the 2 points taken while grading of brain atrophy?
Sorry, sir.
Yeah, you look at the
Yes,
depth
sir.
of the sulci, you look at the width of the gyri.
Yes, sir.
No numbers, but this is a graphical visual impression, what you say. Therefore, when the patient, there is advanced Alzheimer's, the sulci are much more deep and the gyri are very thin, right? Therefore, they are graded as mild, moderate, severe. Right. Okay. We will take that this is Alzheimer's. What is the present status of drugs in the treatment of Alzheimer's?
Yes, sir. So we can give acetylcholinesterase inhibitors, donepezil.
I'm asking a specific question. What are the modern advancements in the treatment, in the diagnosis and treatment of Alzheimer's?
Yes, sir.
At present.
Yes.
What
Sir.
are the drugs at anvil?
Yes, sir. So there are firstly, there are few options like beta secretase and gamma secretase inhibitors, passive and active immunization against A beta. We have solanezumab, that is a gamma secretase inhibitor. I'm not sure, but the name is solanezumab, and also galtranezumab, sir. Bapinizumab is also there. So these are the drugs, sir. And also for tauopathy, again, this is for A beta amyloid plaques. For tauopathy, we can have antisense oligonucleotide.
I'm talking about Alzheimer's. Diagnosis and management. Alzheimer's. What is the present state? If you not, then just go. There has been a explosion in the diagnostics procedures especially of the Alzheimer's, go through them. Hello? Hello?
Sir, I think
I think he's disconnected.
Am I audible?
yes, sir, you are
Yes, sir.
presentation is not there.
Okay, fine. Therefore, just as finishing off, uh, there are now changes even in the diagnosis. What are they doing? For what are the blood parameters
Hello.
being taken, CSF parameters being
Hello.
taken, and what are the new drugs coming? This we have to know, for both from theory and from the practical point of view. Okay.
Yeah.
Yes, sir. Sorry, sir. I lost connection in between because of. Sorry, sir.
Anybody
RK,
want to
1
ask
hour
any
हो गया
question?
इसलिए.
I think
Hello?
2 questions were asked, sir. One was about the episodic memory, whether it is a frontal or a temporal phenomena. Episodic memory is always a temporal lobe. It goes to the medial temporal hippocampus. So it's like a circuit. Even some people ask, expected to be told as a circuit, Pappas circuit, the episodic or the recent memory. Recent memory is usually the Pappas circuit, and episodic memory usually they say it is the hippocampus. Only the immediate or working memory goes to the frontal.
DLPFC.
Yes, sir. And they asked difference between simultagnosia and apperceptive agnosia.
No, I
So
have to
I don't
read.
know. Yes, sir.
I also.
So,
Sorry, about the executive dysfunction also. In the last class, Subhash Kaul sir had.
okay, sir.
But hello.
Yes, sir.
Yeah, I will
Simultagnosia,
both of the
apperceptive agnosia.
questions I will keep in my mind. I will
Yes.
read and I will get back. If I know, I will tell. I will ask Kaul sir also, and I will get back.
By history, I'm also not very sure, sir. It's only by examination, I think we have to differentiate.
Okay, just
Okay.
let me. But Kaul sir had told some point, executive one.
Okay.
He forgot
Okay.
it. I will get back in the next
Sure.
class.
Yes.
Therefore, clinical, I will just last make the final statements. Clinically, we thought more of a progressive dementia involving predominantly the episodic memory. But the finding which was more problematic was of the frontal involvement, where I was not satisfied with the examination. I would go back to the examination. Third, images wise, I think so. If we look at more sections, we could have made a better diagnosis. And fifth, all of us, we should read the. There has been multiple papers both in the Lancet and in the Green Neurology, which talk about the tau, both the CSF and the serum markers. All of us should read about that, and the treatment advances. I agree there are not many advances, but what is the work going on? We should all be aware about. This is my closing part. Anything to be added, please add.
I think just one clinical point I'd like to add here. So actually, when we assess the history, analyze it, it's always better we see where the problem starts. So here, if you see the problem has started in the temporal lobe. So I think whenever it starts, so if you see the problem starting with the frontal lobe, so usually we think in terms of frontal temporal. So where the problem starts, the initial symptom is always, that is where the pathology is beginning. So
Exactly, 100%.
thank you.
I that totally agree with you. And after the problem starting, where is it going? Whether it's going to the frontal, whether it's going to the parietal, whether it's going to the occipital. That also brings out the good narrative.
Yes, sir.
Yeah. Okay.
Thank you, sir.
Thank you, sir.
Thank you.
Yeah.
That was a wonderful presentation.
Thank
Just I would request
Learning a lot
you.
from you.
Pardon?
Learning a lot from you, sir.
No. That's what it's all about discussion, much more discussion. And hopefully we'll keep on with these discussions. Thank you.
Yeah.
Thank you, sir.
Thank you, Dr. Swati.
Shwet.
Thank you. Nice presentation.
Thank you, sir.
Thank you.
Thank you, sir.
Shall we close the session? RK?
Thank you, Dr. Swetha and others.
Thank you, sir.
Bye, everybody. Bye.
Thank you, Praveen sir and Mohan sir and Ramkrishna for beautifully arranging all the things. Thank you.
Fine. Bye.
Thank you, sir. Thank you.
Yes, sir.